Krista Martel from the Well Project, and I want to welcome you all here today for our fifth and final webinar in our 2016 Watch series, where we're going to be talking about long-term survivors of HIV. Before we get started, I just wanted to let you know that due to some unforeseen circumstances, one of our panelists, Maria Mejia, is not able to join us today. And so we are just kind of having a little faculty review talking about, should we proceed with a webinar today or try and reschedule. And I wanted to kind of put it out to everyone in the chat box that we are happy to walk through and, go through the slides today and then provide credit for anyone that's interested in, getting their certificate of completion. We will not have the voice and experiences that we were planning to include today from Maria, who has been living with HIV for the past 28 years, and so offers, a lot of, personal experience to some of the topics that we're going to be talking about. And Tranisha was born with HIV and also is going to be offering, her experiences, but I know they're very, which was what our plan was, to offer these two different types of experiences. So in the chat box, if you, given kind of the current state of everything today, and if you are interested, and if you can just let us know if you would like us to continue, and we would even welcome voices from the participants on today to include in the discussion. If you could just say yes or reschedule, or any of your thoughts. And if we have quite a few yeses, then we're planning to just move ahead as planned today, and then possibly even offer it an additional time in the early part of next year, so that we can have kind of the same discussion. Okay, so at the moment I'm seeing quite a few continues and yeses. So, all right, and so we are happy to do that. And if anyone is interested in, lending their voice, to share experiences, obviously we have that all through the chat box. But if you actually want to come onto the phone and or the line and speak and share personal experiences via phone, if you could just send the presenters a message and let us know, and then we can try and figure out how to kind of unmute, or we can unmute all the lines at some point. Okay, so that said, I will move forward, and so I'm hopefully everyone now is familiar with the Well Project who's on the line, but we are a nonprofit organization with a mission to change the course of the HIV/AIDS pandemic through a unique and comprehensive focus on women and girls. And we are working to do that by leveraging technology to improve health outcomes and increase quality of life for women and girls living with HIV. Our main sources of doing that are through providing information and education, community support and connectivity, as well as advocacy building. And pretty much most of our resources can be accessed via our website, thewellproject.org. And about Watch, it's the Women's Advocacy and Treatment Coalition on HIV, and it's an ongoing treatment advocacy and capacity building webinar series. This year we did it a little bit differently than last, and we spread out the webinars throughout the year. And for anyone who has been attending all the webinars or watching the recordings and taking the pre and post tests, we will be offering certificates of completion. And as many of you know, the webinars are being recorded, and they can be accessed up to 1 month after they take place. We send out an email within 2 to 3 days after the webinar, and with the link to the web page where the recording and the slides and all the additional resources live, and so you will receive that in the next few days. And typically our webinars last approximately 90 minutes, and we open it up for a Q&A at the end. And as you are all mostly doing at the moment, we do have the live chat box on the left side to answer questions, or we will take those down as you pose them, or if you say, hey, I'd like to chime in here, and can you unmute my phone, we can work on that as well. Okay, so at this point I would like to recognize our great speakers that are here, and ask both Dr. Theresa Mack and then Tranisha Arzah to introduce themselves and say a little bit about their work and their experiences as it relates to our topic today. So Dr. Mack.
Okay. Good afternoon, everyone. My name is Theresa Mack, and I've been an HIV specialist for over 20 years. I'm based in Harlem, New York. I am currently the medical director of Mount Sinai Doctors Faculty Practice, where we see both HIV and non-HIV. And I have many, many patients that are LTF. And I think this is a very timely topic, and I'm happy to participate. And I want to thank the organizers for inviting me.
Thank you, Dr. Mack. And as you can see on the slides, we're fortunate enough to also work with Dr. Mack on, who is part of our review team that reviews, a good number of our 100+ fact sheets that we that we update and review annually, and she is one of our treating providers that reviews to make sure that we're hitting all the aspects that we need to from a clinician standpoint. So we appreciate her involvement there as well. And Tranisha.
Yeah. Hi, everyone. My name is Tranisha Arzah. I have been living with HIV for 26 years now. I was born with HIV. Currently, I work as a peer advocate at Babes Network within the YWCA here in Seattle, Washington. I provide services for women, girls, and heterosexual men who are impacted by HIV and their families. I've been doing that for about over 3 years. I'm also a blogger. I'm a huge activist in the community and also the nation. And I'm just really glad to be here. Thank you.
Great, thank you, Tranisha, and thanks for being here. And my name is Krista Martel, and I'm the executive director of the Well Project. And I just want to again thank everyone for being here. There's a lot of uncertainty ahead, and we do plan to double down at some point to kind of focus in on some of our efforts and advocacy around the future. But for now, we want to make sure that we cover the topics that everyone has come here today to discuss. So I just want to thank you for making yourself available and being involved in advocating on behalf of yourselves as well as others. So, excuse me. Oops. Okay, so today's agenda is we're going to just do a quick recap of the first part of this two-part series that we're doing on long-term survivors and we'll talk a little bit more on the next slide about what we discussed last, or 2 weeks ago, I believe. And then we're going to be talking about more of the mental health issues as well as isolation, sexual health, financial considerations, and long-term planning as it relates to long-term survivors today. So that is our agenda for today. Okay, so I'm going to hand it over to Dr. Mack, and I did see that we have a comment about the topic of today in mental health as it relates to the election and how there's a lot of this is intertwined, and I think we should start going through, and that can come up as we get through some of the topics and move through the agenda, and also as we get into the Q&A. So thank you for bringing that up, and we'll put that in. Okay, so Dr. Mack, do you want to, this is the recap for the part 1 of the webinar.
Okay, all right, thank you. Okay, so at the first part 1 webinar, there was a definition of what are long-term survivors. And these are individuals who have lived with HIV for many years. And it's been broken down into 4 components. We have the pre-heart era, which is anyone who was living with HIV before 1996. And that was the year that we had our protease inhibitors, which were the treatment drugs, to me, that changed the face of living with HIV from being a death sentence to being a life sentence. And then you have the post-heart long-term survivor, and that's someone who's been living with HIV for more than 10 years. And then the perinatal acquisition, this is someone who was born with HIV, and we're lucky to have Ms. Tranisha, who will give us more insight. And then the HIV negative long-term survivor. This is anyone, partners, family, activists, healthcare professionals, myself, anyone who is directly supporting people living with HIV in this epidemic in the early days and even now. And so we've also noticed that there are some physical and treatment-related concerns associated with the long-term survivors. Your physical health, treatment and challenges, aging, inflammation, comorbidities, menopause, and sexual health. Can we go to the next slide? Okay, and so we have a poll question.
Yes. Can you hear me now?
Yes.
Okay. So let me just bring up the poll here. Okay, so our first poll question is just to help everyone know who's on today's webinar. Which of the definitions that Dr. Mack just reviewed do you fall into? Okay, so an interesting percentage that we have. We'll close the votes in just a minute, but we have just one pre-heart long-term survivor and 22% post-heart are living with HIV for more than 10 years. One who's born with HIV, and then 68% who are HIV negative long-term survivors. So I'm going to close the polling up. So back to you, Dr. Mack. So I don't know. I mean, given what's going on, I don't know that I'm very surprised, but I think it definitely puts some of the impetus as to, how for those who are working in the field of HIV with long-term survivors, as someone brought up, the mental health services and how we can really work to address that as we move forward with the situation at hand. So, Dr. Mack, do you want to go through this list? Okay.
No, I think this actually reflects our practices. We have the most of people living with HIV for a long period of time, and some is greater than 10 years. Definitely, you have, and you're happy to have, the HIV negative long-term survivor. As far as people who are perinatally infected, it's, in my particular practice, it's really small. But again, they're not small people, and it's more in an adolescence or that pediatric, and you're bridging to adulthood. And so we definitely don't want to forget them, and their concerns may be a little bit different than the other groups. And then that last group was the pre-heart long-term survivor before 1996. And yes, even in my practice, I'm still having these patients, and some have switched over to medications, and some have not. And so we have to deal with each person as an individual. And this is a disease that we have to look at each patient and try to customize our care.
Thank you. Yeah, definitely agree. So next we are going to talk about the AIDS survivor syndrome, which we also touched upon in the last webinar. So, Dr. Mack, do you want to go through?
Sure.
Okay.
So the acronym is ASS, or AS, and it really refers to psychological results of living through the most brutal years of the HIV pandemic. And symptoms can include anxiety, but there could be others that are not listed here: nervousness, depression, irritability, lack of future orientation, low self-esteem and self-worth, substance abuse, social withdrawal and isolation, and survivor's guilt. And the people who are long-term survivors before we had heart really are especially vulnerable. And this particular syndrome has been compared to post-traumatic stress disorder, which is when soldiers go away to war and they see all of the atrocities, and then they have to come back, and still they're having flashbacks of all of the negative things that had occurred there in that particular country in war. They have lots of different symptoms that get manifest as insomnia, depression, bipolar, and this is what we're also seeing with people who are living with HIV, having these multiple traumas over a long period of time. And we don't have a lot of published studies, but if you ask any person who is taking care of people living with HIV, you know that this is a major problem. Another symptom that I think I would even include here was scared to date or not wanting to date. And so I would like to ask Tranisha if she could give us any examples of what she has been experiencing.
Yeah, sure. I mean, I definitely have experienced a little bit of a lot of these symptoms that we see here on the slide, as I do think that most people living with HIV have at some point in their journey. Currently, anxiety is a really big one for me, as I hear for a lot with the members of Babes Network. There's a lot of anxiety, a lot of feel of depression that comes up about around our diagnosis, around some of the things that we feel like we may have lost when we found out that we were living with HIV, and especially for long-term survivors, I feel like there's a sense of not getting to a place where we once were, which has been really interesting to see. But yeah, anxiety for me is definitely a big thing. And for women, I know that the feeling of self-worth is definitely difficult. And I've been trying to do a lot more work around how do we gain our self-worth, our self-esteem back as long-term survivors, and kind of working through that.
Okay, thank you. I also want to say that what I have also seen in my years is that it's pill fatigue. My patients sometimes are just very tired of taking the medicines, and then they want to try different regimens. And if you go back to the pre-heart, you almost needed a beeper to tell you when to take the medicines and which ones had to be taken with food. And so they do relive that again. And depression and overweight and dating are major things that I see and have to deal with on a daily basis. In addition to hepatitis C and substance usages, and some ways that the AIDS survivor syndrome manifests itself is that medications, or the post-traumatic component of it, the medications they may take intermittently. And it's all about quality of life. And so my patients explain to me that I'm undetectable, but I want you to know, doctor, I don't take them as regularly, as I should. And so we have discussions, around that and what could be some of the implications of that. Does your T-cell count fall? Will you develop opportunistic infections? And what I think is so very important is that since there is no published studies to tell us how to act, you must have this relationship with your primary care provider, that you can talk to them about everything, and that you not have to feel rushed through the visit, because these are things that do take time to address. Okay. All right, can I go to the next slide?
Yes, sure. Thank you.
Okay. All right. And so under mental health, a lot of people have the survivor guilt. And they have said, why am I still here? I think this is a beautiful quote. And my friends are gone. Not a few thousand, but there's millions. And so with depression, we do see a lot of people who are living with HIV experiencing depression. And it could be in the form of isolation or not knowing really what the future holds. it's very, very prevalent among long-term survivors. And there is a high rate of depression even among young people born with HIV. And I think since there was a comment about the recent election, this caused for us to be uncertain and depressed about the future. But I think one of the things that we must do is to advocate for ourselves. And I think we will see that there are many more people that would be willing to help us and get on our bandwagon because they are in a similar situation. And I know that people were just really upset. And even here in New York, it was more or less hatred, and it's okay to mimic people who have diseases, and it's not helping and marginalizing races, gender, that's everything that we have not stood for, even as a country. So I do understand people's concerns and their frustrations, and I say we'll all band together and advocate so that we can maintain what we have and move the country forward. Krista, did you want to do?
Yes. Thank you for adding that. Yeah, I mean, I think, it's all very new for us. And, I was just at a conference with a bunch of community leaders and was able to kind of be in a little bubble around a lot of people who are, as much as in shock and sad and grieving, but also dedicated to really making sure that we don't stop fighting, and I think that's the Well Project's position is to, figure out now, what can we do in addition to what we're doing to continue to work on advocating on behalf of and alongside with women living with HIV and people living with HIV. And I think one of the things that I'm recognizing and that we're going to be talking about and we are talking about today is the mental health issues. So, we're going to really be putting some focus into how we can utilize our existing resources or add to resources that, may be able to help provide some sort of mental health services, through possible volunteers to people living with HIV, especially, if resources are cut back through funding. But we're going to be working on this and more to come soon.
Thank you, Krista. I also wanted to know if Tranisha would mind giving us a perinatal review. She talked about it a little bit, but I wanted to know if she wouldn't mind going a little bit more in depth.
Yeah, definitely. When I think about depression, for me, it looked different because I had my first stage of severe depression happen when I was in middle school. So I was in my early teens, which is really hard for a very young person to have to go through when they don't even know exactly what depression is and why they're feeling these things. And so I went through the whole, why am I still here at the age of 10? I went through that because I lost a lot of people early on. So I went through a lot of traumatic experiences as a child. And I still lived through it and I understood parts of it, but I was definitely feeling it the most. So I dealt with the sense of feeling like I didn't belong for a very, very long time, and trying to find my place. which is a lot for children to have to think about and comprehend and grasp. We don't really, want children to feel like they have to figure it all out at such a young age. And so it was really, really difficult. Luckily, I had, support systems intact, that I was able to work through it. But I definitely, because of that depression, I had, suicidal thoughts that came up and some really difficult things that I didn't really know how to deal with because of the great loss that I experienced, because I was living with this condition that I didn't really understand why it happened to me, So yeah, I definitely feel that for sure.
Okay, and then you said you had a good support system. Do you mind sharing that with us? And was that support system how you were able to overcome some issues of depression? Do you still experience depression?
Yeah, so my support system then, I had a lot of adults in my life surrounding me in very different ways. I had case managers, doctors, nurses. At that time, I was in foster care for about 5 years in Seattle, before I got adopted at the age of 9. And I had my foster mom, who was definitely there through a lot of the changes. I definitely, even though I had all these people surrounding me, I definitely felt alone most of the time. I think because I felt like people didn't really truly understand what exactly was going on with me. They couldn't really grasp what it felt like to live with this condition and to have so much pressure in the same way too.
Okay.
So I mean, and then growing up, I had major influences. A lot of women. I had a lot of women who were supporting me throughout the years of growing up, and that was extremely vital in my my care. And today, I still deal with depression, but I think now the difference is I have coping mechanisms intact. I figured out, what helps and what doesn't. I also have folks that I can turn to so I don't feel alone. Sometimes I need to feel alone. Sometimes I like to be alone, and that helps. But I think just kind of figuring out, what works for that person, and making sure that you have things in place, just in case something happens.
Okay. Thank you. And I'm glad you alluded to that you can be depressed, and it's like web and ties. You're not always completely depressed. You may have a depressed mood and moment at that may last for weeks, but we're trying to learn what things we can do to kind of avoid that or help us through it so that we can go on to being in a non-depressed state. And actually looking at this is a life sentence, it's not a death sentence, and all the things that will make me happy in being alive is what we want to make sure that we are addressing. So thank you for that. Can I have the next slide?
Yes, and I'm just going to add, I'm just kind of working on the logistics, but Gina Brown, who is a part of our WRI membership and close to the Well Project, and also a long-term survivor, has agreed to come on and also contribute some of her experiences to the panel. So in the discussion. So as soon as we are able to figure out which phone line to unmute, we're going to add her, and I'll let you know when she's on.
Oh, great. So, wonderful.
Yes, and we thank her for, and so we're looking forward to having her come on. So, okay, so here's the next slide.
Okay, so the next slide, and really Tranisha even talked about this, was the isolation that you can feel from community and family. And this isolation can make you have really negative health effects. And we just don't see this with HIV. We do see this in a lot in our elderly population, where they isolate themselves from their families, and then they have no stimulation, and their diabetes becomes worse, or their hypertension becomes worse, and they have all these higher rates of death from chronic health problems. So it's actually the same. This is not a new phenomenon. It's the same phenomenon that we see. You isolate yourself from the community and family. And what really is that we have to do this, we really need to have a score of mental health providers and a social support, and that people who give you a sense of purpose in your life. Those are going to be very key to decreasing this isolation feeling and improving our mental health.
Okay.
And,
Gina is now on, so when you're done,
okay.
Dr. Mack, if you want to,
okay, good.
Just so you know.
Let us have. No, this is wonderful. Let us have Gina Brown tell us, about isolation or depression and how she has dealt with it, and then I just wanted to say a couple other comments.
Okay. Gina, we've unmuted from our side. You may need to click *6 to unmute your own line.
Okay. Hello. Can you hear
there
me
you
now?
are. Okay, thank you, Gina. We're so happy to have you join us.
Hello,
Thank
everyone.
you.
Thank y'all for having me.
Sorry to put you on the spot. Maybe you want to, before
okay.
you dive right into this topic, if you want to maybe say a little about yourself first, so people know, those who don't know who you are.
Yes. Okay, I am Gina Brown. I live in New Orleans, Louisiana, and I've been living with HIV 22 years. And this last year has been really, really hard. I made 50 in January, and it was like I made 50, and then I celebrated 22 years of living a positive life, and it hit me that a lot of people that I know are no longer here. When I started doing this work 14 years ago, it was 4 women. We were all peer advocates, and I'm the only one that's still living. It was really, really painful when I started thinking about all of those things, and I found myself isolating, from other people. Not so much because of because I didn't want people to know I was living with HIV, because everybody knows that. I'm very open with my status. It almost feels as if I'm trying to do this by myself, knowing that there's a lot of support out there. And I'm not blaming anyone but me, because I do isolate. I get off work at 5 o'clock. I pull into my driveway, and I go in my house, and I don't have any other interaction with people until the next morning when I go to work. Of course, I'm depressed, and just thinking about the last, part of my life that I'm alone. I'm not in a relationship, in a meaningful relationship, and that's really painful. I think sometimes we react to things a certain way when we're young, and I listen to Tranisha, and thank you so much, Tranisha, for always bringing your truth to the conversation, and then I realized that when I listen to young people like Tranisha, that we deal with this depression, we deal with these feelings regardless to how old we are or how long we've been dealing with HIV. I am in therapy, which I'm looking for a new therapist right now, because the way I work now, it's hard for me to meet with my therapist every week the way I was meeting with him. Plus, I wanted to get a female therapist, because there's some female-focused things that I need to be working on. And I think I need another woman to work on those things. I have a lot of support as far as the community and my family when I allow them in. And I think a lot of times with isolation, that's what we do. We don't allow other people in. We'll say, we're isolated from whatever the situation is, but how much is it us that's like pushing other people away? There's no reason that I should go in my house at 5 o'clock and not interact with other people after that. There are people that live on my street. I have a neighbor. I have people across the street. I can go outside and talk to these people if I truly wanted to, and I don't even know what keeps me from doing it. This year at USCA, we watched the movie Last Man Standing, and I broke down because I thought about my own life and how it feels like I'm the last woman standing sometimes. There was a lot of love in that room, and I know everybody in that room who knew me loved me. I know that. It's just the case of being around so long and seeing so many people die, seeing so many people check out, and you realize, or either not so much realize, but I ask myself sometimes, like, why am I putting one foot in front of the other? Why am I getting out of the bed in the morning? And then I remember that I do all of this because it's someone who may be going into their first year of living with HIV, and I want them to get to year 22. So I need to be here to show them how to do that and have that conversation with them. So even in my depression and my isolation, I still look to other people to see how I can help them, not so much how people can help me. I'm really appreciative of the Well Project for putting this workshop, this webinar on, because it's really important that we remember that we are long-term survivors. We are survivors. And we can continue to do some great things in order to be here, like take our medication, go to the doctor, learn everything we can about this virus. But more than that, we can work on our depression. We can work on our mental health issues and make sure that we're not just living a healthy life with HIV, but we're living a healthy life mentally and physically. And I think that's about all I have for right now. But thank y'all for letting me share that with you.
Oh, no, thank you. It was beautiful. I just wanted to say two things that I have noticed. People are living longer. They're having better health. But the stigma and isolation and relationship issues are very big. And a lot of times it actually breaks my heart for people to say that, oh, no, I'm damaged goods. I'm not sexually active. And when you say things like that, you're putting a negative connotation on yourself. And so I do spend lots of time, with my patients, and it's trying to get them to see that, no, they're not damaged goods. God didn't make any mistakes. And so just trying to get people to see that, trying to get them to accept a therapist, to accept a psychiatrist is key. And we also want to utilize these things and not be scared to say, well, I don't want to see a mental health provider. And when I say that sometimes to some of my patients, they'll say, I'm not crazy. And I said, it's not about being crazy. It's about having someone who can talk to you to give you the tools so that you can address different issues in your life. And it's all about living a happier life and living your life, not living a death sentence. So I do appreciate Gina, when you talked about our relationships, and when we go to this next slide, it's still talking about isolation, but things that contribute to it. Can we see the next slide?
Mm-hmm. Yes. Here. Oh, we do have a poll question here.
I'm sorry. Sorry.
Oh, that's okay. I'll bring that up. 1 second. So this question is for everyone on today's webinar. Is, have you ever suffered from depression? And sometimes people aren't sure, so we included that answer as well. And just so you know, these polls are anonymous, and there's no tying back to whatever your answer is. It just comes through as a vote. So right now we have around 75%, 76% saying yes, and 23% saying no. So, which does correlate to a lot of the percentages we see regarding depression in women, and then even more so in women living with HIV. And so I'm at this point going to stop the vote, and I will advance the slide.
Okay, so when I look at those numbers, that's exactly what you see in a practice. The 23% who are not suffering from depression, it would be nice to know if they are in treatment or what are some of the things that they're doing. And I'm very happy to see that no one thought, I'm not sure, because I think you know either that you're happy or you know you're not unhappy. And I think it's those two choices. So could I have the next slide that talks about, unless Krista, you wanted to talk any more on that?
About this? Oh, sure, yes, to move. Okay. This slide?
Oh, no. Let me.
Oh,
it's still
back
the poll.
to this.
About the poll. Okay, right.
Oh.
So then these are just some factors that contribute to isolation. Multiple losses, that could be friends, family, jobs, apartments, any trauma, and that trauma could be specific to you. What is trauma to one person may not be the same trauma to you, and that is why it's very important that you do get a healthcare provider who takes an interest in you, the whole person, not someone just providing medication, but talks to you and find out what is your particular personal trauma. The decreased ability to leave home or get around town, Gina, that resonated when you said you go home. There's people there. You just go in the house, and sometimes we just feel like we want to be by ourselves. But it's a real concern. Substance abuse, financial concerns, and caregiver duties, especially for women. I have a lot of patients who are taking care of their families, mothers, children, and may not have disclosed due to the stigma. And I always say, you're the perfect person to get rid of that stigma because you're doing everything for them. And if they see that you could do all of this and you are living with HIV, that's not going to change. You're going to say, well, Mom can do it, then, I can do it. And so, but those are simple statements for me to say, but it's very difficult for women to understand that, and that is why you want to make sure that they keep coming back to you and you can give them a safe space. And a lot of times there is no mental health therapist. We have a shortage, I feel, in our armamentarium when we're trying to take care of this particular illness, and sometimes the primary care provider has to be that person. And I think Tranisha and Gina, they just have anything else before we go on to the next slide?
No. Okay.
I would like Tranisha and Gina. Is your trauma, or the two of you have the same type of trauma, or you have no trauma? Is it more individualized that I see in my practice, or you're not seeing that or feeling that?
I have a lot of trauma. I'm a survivor of childhood molestation. Also, I'm also a survivor of intimate partner violence, so I have a lot of trauma.
Mhm. I'm sorry to hear that.
Oh, and I'm good now.
This is Tranisha.
Yes.
Yeah, I mean, yeah, I think it's hard not to be human and not have some type of trauma, to be honest. We experience a lot of things, and so many levels impact us. And being in the foster care system, losing my mother and a brother to AIDS-related complications, it brought a lot of trauma in my life very early on. And I've grown up with that, but I've been able to learn how to deal with that trauma and also learn where it comes from, which I think is really important. Because trauma definitely can eat at you for a very long time if you don't face it. So I definitely learned to face it, and having a therapist and being able to talk to people, and kind of do some soul searching has definitely helped me, better live with HIV and not suffer with it.
Mm-hmm. All right, great. Thank you. And so the next thing we want to talk about is sexual health, but it's not in a silo. You can have, we talked about it with the isolation and with the depression, but we really wanted to make sure that when we talk about HIV and aging, that we know women who are mature, they remain sexually active. What we had and what we were seeing early on was that the women who had completed menopause really were not using condoms. And they said, well, I can't get pregnant. And so we had to educate a whole community about sexual health and protecting yourself from sexual infections. And getting back out in the dating game after your partner has died or after you've ended a long relationship can be frightening for some women. And if they had not experienced intimate partner violence, this is the time that when they come to their doctor, we need to make sure that we are questioning them about this particular issue. And again, the sexual risk-taking can be an effect of past trauma. It can also be post-traumatic, so that's why, again, it's a symptom of the AIDS survival syndrome. And I really do feel that as providers, we have to initiate the conversation about sexual health with our long-term survivors. It's important that they see a gynecologist, and if you are younger and of childbearing age, you still need to have conversations about your sex, your sexuality, and also what are some of the contraceptive resources that are available. I would like to see if Tranisha and Gina can expand a little bit more of what I just said and what's on the slide.
Yeah, sorry. I just had to do something. I think this slide is really, really important around sexual health and for older women and, younger women and all people. Um, for my experience around sexual health being a young person or working with youth, um, obviously sexual health is a huge impact. That is difficult to navigate in the sense that it's about providing all the necessary tools for young people so that they can make safe and right decisions for them. And unfortunately, we live in a society where all of those tools aren't provided to young people, which is really unfortunate. And so because of that, we've had to deal with the consequences of, new HIV infections that continue rising in, the 13 to 22 age range. In this day. And that's just really, really frustrating because we have so much information now around having to protect yourself. It's not just about condoms anymore. There's a lot more other tools. There's PrEP, there's even PEP, there's all these other things that we can consider now when it comes to our sexual health. And unfortunately, we're just not having these conversations enough with young people and just women in general. I even noticed with my members of Babes that these conversations might be happening with partners, but there is still a lot of information that or a lot of barriers within those conversations. Yeah, that's what I have to say.
Mm-hmm. Thank you for bringing up PEP and also PrEP. I actually did have a conversation right before this webinar with a woman who I've taken care of for years, and she told me that she was pregnant and she miscarried, and her partner is HIV negative. And so I said to her, you need to have your partner come in and we need to talk, because if you're really serious about having another child, the best thing you can do is to make sure you stay on medicines and are undetected. But he also can take PrEP while you guys are trying to conceive. And this is an advocate, and she said, I really didn't think of it, like that. I know I'm on medications. So we have two new, or not so new, prevention tools, and we really, providers need to make sure that we are offering them to everyone. So thank you, Tranisha, for bringing that up. Gina, did you want to say anything?
Thank you.
I think it's a poll.
So Gina actually had to run to a meeting. So I know that there are, I haven't been able to recognize it, but we do have another woman Darlene, who is also a long-term survivor, who is willing to jump on. I do want to say that I know we have a few questions that have come in, and so we're kind of getting to the Q&A period. So if we want to move ahead, and I will coordinate with Darlene about coming on, and thank you.
Okay. All right. Well, thank you. Well, then can we have the next slide?
Yep. Sorry. Okay. So this actually was kind of inspired by a reproductive health session I attended this weekend, and for women living with HIV. And so just out of curiosity for women who are living with HIV, if your healthcare provider has initiated a conversation around family planning, or and I know we have a lot of people who are not living with HIV, so that's probably the non-applicables. Okay, so
wow, that's
yeah, so looks good that of the people living with HIV, we don't have anyone that their provider hasn't. I know that that's not a case across the U.S., necessarily, but I think that's great that we're seeing. Okay, I'm going to stop the vote, and we'll move to the next slide. Okay, Dr. Mack, back to you. Dr. Mack, are you?
I'm sorry. Okay.
Oh, that's okay.
All right.
No, sometimes technology cuts out. Okay.
Okay. So the financial considerations with the AIDS survivor syndrome, much longer life expectancy, and for someone taking care of patients for a long time, no one really saved or, did anything to think about future or like what was next. There was always panic about the future, but no one planned for it. And it wasn't so much an inability to plan, it was like what was the point. But panic and inability are really symptoms of the AIDS survivor syndrome. Many long-term survivors have not saved, and even people. It is hard to save in this day and age, but nothing was being done to think about, what are we going to do for the future? And some of the public assistance that we had, people have to be at a poverty level that you cannot even save on with incomes that low. And so again, people had not been able to work as well. There are going to be gaps in the history and going back to work, whether you're living with HIV or not. We do see problems with aging. And so these are the same challenges that we see for long-term survivors. So in essence, we didn't think of that we were going to be having a longer life expectancy, so there were no plans. And then with all of the eligibility requirements that a lot of our patients are on, it's just enough to get by. It's not enough to put away for a rainy day. And then again, not having have not worked for a long period of time, trying to return back to work and experiencing the aging and the long gaps in history. Does anybody want to comment on that? Okay. All right, so can I have the next slide?
Yes.
Did somebody want to say something? Was that Tranisha?
No, that's Krista. And to go back, someone had asked in the earlier part and was not able to address it then, but a question about lack of future orientation that was listed in the bullets under the AIDS survivor syndrome. And I think, and Dr. Mack, you can maybe speak to that, but I think that ties into kind of what we're talking about now, that many people felt that they're having a hard time planning or not knowing how long to plan at the time.
Right. And what bullets, what was it?
It was in the AIDS survivor syndrome list of symptoms that, people who were...
Oh, lack of future orientation.
Yes, exactly.
Yes. Okay.
And they were just asking what that meant, and we didn't get to cover that at the time, but I think maybe that is what we're talking about here.
Yes. Yes.
Okay, I just wanted to make that tie tie together from the question.
Okay. Okay, and so this slide is unexpected long-term planning, and so we want all of the long-term survivors to imagine the future and actually to plan for it. And we want to plan for end of life, whether this is a healthcare proxy, a living will, life insurance for HIV, living with HIV. We definitely want to have more of a control of this, so it's not a burden for our loved ones. And when you take control, this is a form of empowerment. And I like this statement here where it says it means deciding not just where belongings will go, but how long you wish to be treated. And if there's a time when you can't make your own decisions, who do you think represents how you feel and can make those decisions for you? And I think having long-term planning is not just good for LTS, it's good for our entire patient population, whether you're living with HIV or not.
Thank you. And I know Darlene was the other woman that was going to also contribute, and she should be able to talk. Darlene, are you there? Darlene?
Right.
Are you there?
I'm here.
Okay, great. So I didn't know if you wanted to contribute to this particular portion of the webinar or anything we covered.
I'd like to do both this one and the previous slide, if possible, if you have time. Sure. If not, we can go on.
Yeah, no, I mean, if you definitely want to, and then I think we're kind of towards the end. And
this is Darlene. Let me tell you a little bit about myself. I'm in Louisiana, not too far when Gina was, and I was so glad she came on. I've been having nothing but computer problems. I've been trying to volunteer since before. But it's coming to the financial considerations. I've been living with HIV now for 27 years. And the first 8 years before the new meds came out, I was preparing to die, living to die, moved home to die, and realized that I was able to get on new meds and that I wasn't. And then I had to learn how to live all over again. How do I plan for the future? I did have a part-time job. I'm also one of those retired ones that at the time I started, the most I could make was $400 a month, and that's not very much. Finding an employer that would hire me under the table wouldn't do it. So it's just hard to live on nothing. Time has gone by. Now that cap is now to up $1,000. It's still, when I started looking for work, I told the man, look, I need extra money. I don't care. I'll work 40 hours a week. Just pay me $1,000 a month and I'll be happy. But he said, we can't do that. So trying to find a job has been almost totally impossible. Now that I reached 66, I can go back to work and make anything I want to make and be able to keep my benefits. But my problem is I'm 67 and finding a job is impossible. I'm too old. I'm scared. I'm in panic mode at times because I had to give up my apartment. I couldn't afford my little bit that I am getting from Social Security to pay my living expenses, much less pay for unexpected like car trouble or doctor visits that I wasn't counting on or anything like that. So what I've had to do is move back in with my sister. I am now from a 2-bedroom apartment. Everything's in storage, and I'm in a 12 by 12 room. Depression is settling back in. Throughout this whole thing, I could have talked on each and every one because I am a chronic depressant. And I'm trying my best to stay out of getting into that too depressed mode because I know where that will lead me. It'll be back to wanting to die, and I don't want to die. So what I try to do to get beyond that is I help others. I try to get out of myself and not worry about it. But I'm here to tell you, going back in my little room every night, those walls begin to close in and it gets scary. So that retirement, a youth remission for being permanently disabled, that's where I'm at. I'm permanently disabled. I'm not disabled because of HIV. I'm disabled because of mental problems. My mental problems is what's gotten me here. I've had so much trauma in my life. Going back to work, I haven't worked in years, and trying to find work with that long gaps, it even made it impossible before I got to retirement age. So it's hard. So if you want to go on, you can go on to the next one, unless anybody wants to say anything.
Thank you so much for those comments.
You're welcome.
And sharing.
Oh, you're welcome.
Yes, thank you.
And at the end of life planning, I just want to say when I was first diagnosed and I was forced to retire due to cognitive problems and everything else going on with my health at that time before I started getting better, I went ahead, and that was the best thing I could have ever done. I paid for my funeral. I planned everything out to who's going to sing, who's going to preach, what songs are going to be played. I've even gone as far as do my own program. It was such an empowering process in doing it. And when I handed that all over to my sister, she couldn't believe that it was all planned, because we have lost many a family member that we've had to go in and do all the planning for them. And this is just a relief, not just to me, but to them. And I thank God for it. So I would encourage, you don't have to wait till you live 10, 15, 20 years with this illness. Plan your end of life planning. It is very empowering. Okay, I'm done.
Thank you.
You're welcome.
Thank you very much.
You're welcome.
So I'll just jump in, and then I know Dr. Mack and Tranisha ask you for any additional comments. This is, to this, not to make things harder, but I thought this was a really interesting, issue that we need to think about, that one of our bloggers wrote about. The quote is, "How will we be treated as elders in our twilight years?" It's coming for so many of us who were told we had 6 months to live. Now it's 25 years later, and I'm left to ponder and worry about the people who will tend to our needs as we start losing the ability to tend to them ourselves. And just kind of talking about the care and issues that, in retirement homes, and it's we know we still are battling a lot of stigma within healthcare systems, and it's kind of a different setting that we have to be looking at in terms of for advocacy and education. And this quote is from one of our bloggers who is talking a little bit, more, well, I'll just read the quote. An ordinary woman who has lived an extraordinary life, my attitude is of gratitude for this life I've been given. The more I can share gives my life meaningful purpose. It's my daily mission to help inspire and motivate others to be kind, compassionate, and above all, hopeful. So we just wanted to talk a little bit about this, and then talk, just provide some things that we have found, outside of what you've heard today, both via the chat, and we thank people for, entering some of their experiences and how they've overcome things, and also through our panelists and Dr. Mack as well. So we just want to try and end on a positive note in terms of, here are some things and tools that have been helpful to people, and I'll ask Tranisha if you want to talk through these.
Yeah. If you are a long-term survivor, we know that we have faced many adversities through this journey. But I do know that we are resilient as hell. Not only are we surviving, but I really like to believe that we're thriving with HIV.
Amen.
I want to thrive with HIV, not just live with it. And these are some of the things that we can do to get to that point. One of the things is taking charge of your health, whatever that looks like for you, but learning about the medications that you're currently on, the ones that keep coming out, bring this up to your providers about maybe changing treatment if that's an option, if that would make things easier for you. And having a good relationship with your healthcare provider is vital. I always said that if it's not working out, then change. They're in the field that they're doing to make sure that you live a long and healthy, productive life with HIV. And if the relationship is not working, then you can interview another doctor that fits. I've had many doctors throughout my journey, but when I had a really poor relationship with a provider once, my health was really poor. I was suffering. I wasn't able to feel like I can talk to my provider about things. I felt judged, and that was definitely making things worse. Also, keep on top of diet and exercise. This is a difficult thing for me, I know, and for other folks as well. I like food, and I don't actually exercise very often. I don't drive, so I walk a lot and I take the bus. But I'm working with my provider right now to make sure that I'm doing some physical activities, even if it's just for a few minutes, like dancing, which I really enjoy. Also, getting support. If that's support within your healthcare system, a mental health counselor, I definitely advocate for. I've had a therapist since doing this work. It's actually mandatory for us to have therapists because we know that we have our own stuff going on, and I have to listen to what's going on in other people's lives, and that definitely could be really triggering. Finding a peer mentor, that's what I am. Sometimes talking to the people that have gone through similar obstacles as you has definitely been helpful for folks to maintain a healthy and protective life. Joining a support group if that's your thing, and also getting connected to activities and your community, and not only just around HIV, but there's a lot of different intersectional topics that folks can participate in. And telling your story, if you're in a position where you can openly tell your story, that doesn't have to be on a stage or even around people, but it can be online. You can, start a blog. There's so many different ways to speak out and tell your truths. For me, I've been telling my story for a while now. Each time it's breaking down those barriers. Each time I'm being healed. Each time I tell my story, the trauma that I faced in my early years diminishes. So I definitely advocate people for sharing. Thank you.
Thank you so much, Tranisha. I really appreciate that perspective. And so I know we only have a handful of minutes left, and these slides are going to be available on the website. We're going to kind of go through, but just quickly, also finding your purpose. I mean, if you're able to, find something outside of HIV that you also really believe in or volunteer, and see if there's a way to get involved there, and many long-term survivors have been speaking up, and that's why there's more information on this topic and, more research being demanded. And so if you are in a place and want to get more involved in the advocacy movement, there's certainly avenues to do that. And, in that vein, a National HIV Long-Term Survivor Awareness Day has been initiated, and we definitely invite anyone and everyone to try and get involved in that and help raise awareness on a national level. So I just want to make sure that we're getting to some of the questions that have come up. So the next few slides are really just about links, and this will all be available that we'll be sending. These are some biographies of people that are blogging through A Girl Like Me who are long-term survivors, and then we have some resources. So so I know one of the questions that just came through is around fear of getting involved in a support group around stigma, and I'll quickly insert the fact that if people have access to online services or the internet, that places like A Girl Like Me and the community that's been established in reading other people's stories has been a huge source of support for people who especially want to remain anonymous and create kind of a username that's not their own name. Dr. Mack, I think this question is for you. What are some specific tips for coping with treatment fatigue, and how can treatment fatigue be prevented?
Okay. I think for treatment fatigue, it is a big issue. We do have research that says that you don't want to stop.
I don't hear anything from you. Nothing. Okay.
Can everybody hear me?
Yes. Sorry.
Oh, okay.
Go ahead.
All right. It is a big problem, but we do have evidence and research that says that you don't want to stop and start. That does more harm than good. That being said, sometimes I have to listen to the patient's body and say, let's give it a trial. Let's take a couple of months off. Let's try to address some of the other things that may be going on, and then bring you back so that we can look to see if it was pill fatigue. Maybe I can minimize your regimen, give you less pills if there was a certain side effect. But it really is a huge problem, and there's not like one size fits all. I just, on those particular patients who are experiencing that, I keep them very close to me. So I will bring them back in 2 weeks. I'll bring them back in 4 weeks. And they're not on meds. I just want to see how they're doing, make sure their immune system is holding up, that there's not something else. And I think it's just continuing to speak with them, and you hear them, and then you also speak. But it is a very real, and it's not an easy problem.
Thank you. There's one question, and kind of we're getting more information about any First Nations groups that someone wants to access, and I encourage you to, if you can email me, and we'll try and put you and connect you, because it seems there's really some dire situation and access to care that is needed. So another question that came through is, how do you engage around the conversations with women who have experienced intimate partner violence?
How do you engage women?
Around as a provider, is there, I guess, maybe a way that you're able to bring up and find out or address issues around people's trauma and intimate partner violence?
Well, I do it in two ways. If they come in with their partner, and it's the first time I'm meeting the partner, I will, we'll just have our general talk, and then I ask them to leave. And at that point, I ask them, is there any particular reason why you wanted this person here? Are you in a safe atmosphere? Or, is anybody harming you? Do you feel safe? And then I get at it that way. The other way, if they come in by themselves, it's just part of, my sexual history when I'm talking with you. Has anything changed? Are you having the sexual relations, men and women, or both? And is your partner hitting you? Do you feel belittled by your partner? I just ask them those kinds of questions, and a lot of time people will laugh, but then there are other people who hadn't really thought that was a question that I was going to ask, and I'm able to get in more information or I'll delve into it. The one thing, though, that I had to learn was that when I ask that question and there is something, I need to have a plan or someone who I can also refer to that can help that particular person, not just identifying, but having a source that I can go to and recommend to them. And we also found that we also found when we did intimate partner violence, we actually thought that we were only dealing with women, and we were surprised at the number of males who had experienced that.
Yeah, that's a good point. We've heard similar. And then I know we're right at the edge of the time. I've put up the last slide that just has a link to the post-test, and that, again, will also be going out in a communication to everyone who is either on the call or registered. I'll just see if we can try to address, I know this is a pretty big topic, and I'm not sure we have the answer, but at least we can talk about it and possibly figure out ways to point in the right direction. But among the financial issues that long-term survivors face, there's a question of those who are now working are in constant fear of losing their ADAP benefits due to increased income earnings. So that kind of situation where if you earn too much, you could lose your treatment, and how to, is there any thoughts around? I mean, I know that one major part of this is, advocacy that we're involved in. Organizations like Positive Women's Network are involved in, and different advocacy networks. But is there any glimmer of knowledge or thought to answer the question?
Oh, gosh, that's a tough question. Unfortunately, for me, no. But it's almost like people aren't able to advance because there's a lot of benefit that you get from all of these services, and if you go outside of that, you lose. And so I've had patients make a difficult decision that no, I can't afford to make more money. I've gone to my job and I've asked them to, downsize it, and so that I can to get more, the appropriate benefits. But it really is it really is a problem, and I wish I had a better answer, but I don't.
Okay. Well, I think it's something that's going to be receiving more attention as we move forward and see how things are, we're going to have to address kind of the treatment and economics and of living with HIV in a very focused way in the coming months. So so we'll be thinking about that and trying to get a better answer. Okay, well, I am just going to say thank you to all of our presenters, and thank you, Dr. Mack, for being such an amazing, committed, doctor and physician and advocate for people living with HIV, and for your input here. And then to Tranisha and Gina Brown.
Wonderful.
Yes. Oh, thank you. And Tranisha and Gina and Darlene for all contributing. I know, these topics are not easy to discuss, and we really appreciate everyone's sharing and helping others both know that they're not alone if they're having similar feelings or issues, and as well as there is hope if and trying to give people tools to think about different ways and working on focusing their mindset on positive for the future. So this conversation's not over, but I just want to thank everyone who participated, and I will, if both hand it over to Dr. Mack and Tranisha for any closing remarks.
Hi. No, I don't have any additional closing remarks. I just want to, say that the most important thing is to really find a provider that you can talk with, that understands you and addresses all of your concerns. That's what it's all about. This is your health. We're here to help you. And I think if you have a caring provider, it will go a long way in identifying all of the concerns that we had with LTS. And I'll turn it over to Tranisha.
Yeah, I just want to thank the Well Project for having me, sharing some of my thoughts and experiences. I also want to thank all the participants who joined today. I know right now is a really heavy time for all of us. And I also want to thank Dr. Mack for sharing all your valuable information and for being that caring provider that you spoke of. Just thank you for having me.
Great.
And ditto,
thanks for everyone for
everybody and the Well Project and the participants. Thank you.
Okay. Well, thanks. And I know a lot of you hung on. We're running a few minutes late. So with that, I will, we will close the webinar. And again, we will be following up with a communication in the coming days that will link to a web page that has the post-test and the slides and the recording, and I'm probably going to include a transcript of the chat as well, so that because I know there was a lot of really great interaction there. And with that, I just want to send the Well Project's love and support to everyone here, and I know we have a lot of work ahead of us, but we're here for you, and whatever we can do to support our community, we're here to do that. So, all right. Thank you, everyone.
Thank
Bye.
you. Goodbye.